Hello, my name is Joanne Pridgick. I will be reviewing eye movement desensitization and reprocessing therapy, more commonly known as EMDR. In this presentation, we will be going over the background and history of EMDR, basic tenets, nature of the counseling relationship, populations best served, current neuroscience research, and the therapeutic process and goals. EMDR began as EMD, or eye movement desensitization, by Francine Shapiro, first in 1987. Now, since it has been used in many different therapy settings, but originally was applied to PTSD. In 91, the name was changed and she added the reprocessing to reflect the insights of the cognitive changes that happen and occur during treatment. And the 2004 began to be recommended for more broader range, the more trauma, and American Psychiatric Association and the U.S. Department of Veteran Affairs recognized it officially as treatment for those other cases. And essentially, what began as a desensitization technique evolved into a comprehensive psychotherapy approach. The basic tenets of EMDR assume the client's problems are driven by inadequately processed memories that are being triggered by life demands. That change occurs through memory reprocessing, and it should only be attempted by a skilled, certified professional. And one reason for this is that disrupting the power of the original event can be extremely troubling and have signals that the therapist established with the client beforehand for like emergency stopping, like safe places. There's all kinds of techniques involved in this therapy. The therapeutic relationship is central to EMDR. Research has shown that the therapeutic relationship accounts for as much of the treatment outcome as the method itself. So there needs to be a high level of safety and trust and a non-judgmental supportive setting from the therapist. And one other study found that when clients are asked to account for their success in psychotherapy, so this is a little bit more general, but includes EMDR, over 90% of the respondents described their relationship with the therapist as the primary factor. And EMDR comes from a psychodynamic perspective and also from the attachment theory is a big part of this. And they relate the importance of the therapeutic relationship to attachment theory. Since initially treating PTSD, EMDR has been found successful in treating a host of other conditions. One such study found acrophobia, successful in acrophobia treatment, as well as all the conditions I have listed on the slide. One study in 1998 found no treatment existed for PTSD designated as well established and empirically validated as EMDR. And another study reviewed 90 journal articles, all with empirical evidence for multiple conditions. The neuroscience research behind EMDR finds it's an evidence-based, trauma-informed modality of therapy. And it deactivates hindbrain regions, which means it helps in the down-regulation of the autonomic nervous system, which is the hyperarousal. And it also activates the hippocampus, anterior cingulate cortex, the medial prefrontal cortex, and orbitofrontal cortex. Sorry, I butchered those words. But all that means, those areas of the brain, is for those are crucial cognitive, affective, and behavioral processes that aid trauma survivors in navigating their challenges. So that is how EMDR is actually changing and rewiring the brain to make it more effective in trauma recovery. So here's the heart of the therapeutic process and goals, like how EMDR looks like when you're with a client. So you've got the traumatic memory or self-destructive thought pattern that's recalled by the client, and it's kept in an active memory by the client. So basically, the client revisits a difficult memory and takes away, by revisiting it and holding that, this process takes away the power of the recalled event or experience. And then next is the disrupting the memory with a bilateral stimulation. So here in this example on the slide, the therapist is using that light fixture, and that light moves from left to right, and that's that bilateral stimulation. Therapists can also use like a metronome, other techniques, their fingers, they kind of go back and forth with fingers. That also stimulates, and that's where that eye desensitization comes from, is that eye movement. So that is the next part. And through that, so the client is focusing on that, thinking of that long-term memory, but bringing it to their short-term active memory. And that lesson, that all this effect kind of accumulates to lessen the power of the memory. And so that memory can be displaced and replaced by either a more positive or neutral memory. And in this process, it's not just about what happens to the client, it's about what's happening in the moment-to-moment unfolding. So that experience that the client is going through is brought up, and the therapist stays really in tune with their client as they are kind of like reprocessing or reliving these past memories, but in the present. And so this works so that therapists can help co-regulate the client's experience. And again, just want to emphasize that the safety and trust in this relationship is essential, and also the trust that the client has in the whole process. And I've used several references, all listed here, and also in this next slide. And thank you so much for listening. I appreciate it. Any questions, please let me know. Thank you.